Respected Chairperson, dear friends, being a train of topics on the same issue, there is bound to be a little bit of repetition. So we'll address the specific issue of what is the current evidence in the literature in terms of the value of physiology in the context of stable ischemic heart disease. We'll go through the following points. All of us know that stenosis is not the same as ischemia. What appears angiographically very significant may not be responsible for ischemia. So there is an important difference. That brings about the value of functional testing. We'll answer the following questions. 1. Can we safely defer PCI in angiographically significant but functionally insignificant lesions? What is the role of FFR guided PCI plus optimal medical management in stable multivessel CAD versus only optimal medical treatment in functionally significant disease? This was addressed in the FAME2 trial. Is FFR guided PCI non-inferior to angio guided CABG in multivessel disease? This was addressed in the FAME3 trial. The emerging role of non-hyperemic pressure ratios has been amply stressed in the previous talks. Non-invasive measures of functional significance like the CT FFR, do they stand the test in comparison to FFR? And can functional testing improve decision making in multivessel coronary artery disease? Whether the syntax score, if it is modified by adding functional indices, the so-called functional syntax score, whether it makes a difference. This is a case that I did recently. A patient, 50-year-old man with diabetes with chronic stable angina with a strongly positive treadmill test, had a disease in the right coronary artery. We fixed it with an angioplasty with good results. And this is the left coronary artery that you see here. There is some proximal LAD mild plaquing. Circumflex is normal. That is the epicranial view, which shows a borderline lesion in the region of the first septal and the diagonal. I've just frozen it for you. And this is the baseline FFR, which was quite significant. This is the RFR. This is the post-adenosine baseline FFR. So we address the LAD here with satisfactory result. And this is the post-procedure FFR, the RFR, and after adenosine. So with that background, physiology tells us what to treat and what not to treat. And imaging tells us how best to treat. And this has been already shown in multiple presentations. There is a significant discordance between angiographic stenosis and functional significance of what appears severe in the angiogram. And the risk of death or acute myocardial infarction in the next 5 years is 20 times higher for those lesions which produce ischemia as compared to lesions which don't cause ischemia for identical degrees of angiographic stenosis. So the first issue, what is the incremental value of FFR in intermediate lesions? Is it safe to defer PCI in functionally insignificant lesions which appear angiographically significant? This was addressed in the DEFER trial. I just want to attract your attention to FFR more than 0.75, who did not undergo angioplasty in the DEFER group, versus FFR more than 0.75, where angioplasty was performed despite the FFR being 0.75 and more. Very clearly, the group in which angioplasty was deferred did much better during follow-up at 5 years. The next question, does FFR make a difference in decision making in stable coronary artery disease? The FAME2 trial answered this fundamental question. Optimal medical therapy plus PCI versus only optimal medical therapy in those patients in which FFR was significant at least in one of the coronary arteries with a value less than 0.8. If you look at this group, wherein 888 patients were randomized in 1:1 fashion, PCI plus medical therapy versus medical therapy. What did we see during follow-up? The top arrow is optimal medical therapy. The blue lines are for optimal medical therapy plus PCI. So in patients with an FFR which is significant in multivessel coronary artery disease, at least in one vessel, optimal medical therapy plus PCI is vastly superior to only optimal medical therapy. So we have evidence now in favor of doing functional assessment in patients with multivessel coronary artery disease. And if you look at the long-term follow-up of both the DEFER trial and the FAME2 trial, the DEFER trial already was shown in the previous presentation. 15 years, the DEFER trial clearly showed that the benefits of doing functional testing continue to be there even at the end of 15 years. And in the FAME2 trial, 5-year data Again, the difference is pronounced even at the end of 5 years. So the early data continues during long-term follow-up in both DEFER as well as FAME2. The third question, does FFR guided PCI stand the test of comparison with angiography-based CABG in non-left main triple vessel disease? This was answered in the FAME3 trial. I won't go into the details. Nearly 750 patients were randomized to FFR guided PCI, and another 750 patients were randomized to CABG based on only angiography. And it was shown that FFR guided PCI was not non-inferior to angio-guided CABG. But if you look at the subset analysis, what is interesting is those patients who had a low syntax score, PCI did better than bypass surgery, even in the FAME3 trial. The last issue has already been stressed, the emerging role of non-hyperemic pressure ratios. We have this comparison between FFR versus IFR in these two large studies, the speed heart as well as the defined flare. They were equivalent, and that's why the current data gives equal status for IFR in comparison to FFR in patients with intermediate coronary artery disease. The next question, how reliable is non-invasive FFR? This was shown in a single center Denmark study with 143 patients, which compared CT FFR versus SPECT imaging, and they were fairly equivalent. So non-invasive assessments of functional testing also was equivalent to invasive testing in the form of wire-based FFR in patients with stable coronary artery disease. This is just 3 case examples to show that the FFR, which was significant in the CT scan, was also showing simultaneous ischemia in the SPECT myocardial perfusion imaging, as well as invasive coronary angiogram and FFR testing. All were producing identical results, just to show that non-invasive FFR is pretty useful in detecting functional significance. The last question, what is the importance of functional assessment in decision making in multivessel coronary artery disease? We have been sticking to this conventional syntax score to help us make decisions in multivessel CAD with low syntax where PCI is better than bypass surgery, and intermediate and high syntax score, bypass surgery is probably superior to PCI. That's what we conventionally know. But you should understand that the syntax score quantifies lesion complexity based only on angiographic parameters, and this can potentially overestimate or underestimate severity of lesions. So if you incorporate functional testing in the form of FFR over and above the syntax score, you get what is called the functional syntax score, and that helps us. You should understand that a lot of lesions which are so-called severe in the conventional syntax score get reclassified into intermediate risk and mild risk patients if you adopt the strategy of taking into account functional importance. And that is shown in this particular case example. The angiographic syntax score was 33 in this example, whereas the functional syntax score downgraded the risk to 12. So what appeared a very high risk for PCI, if you incorporate functional data, it becomes less risky, because a lot of lesions angiographically may look significant. A triple vessel disease can actually be a 2-vessel disease. So PCI may have a role in such cases. And this is the algorithmic approach to functional assessment. I won't go into the details. And in gray zone, where the IFR is in the borderline, you can add it up with FFR. So I'll conclude by saying that physiological assessment of coronary artery disease by FFR has robust evidence in intermediate lesions. It is safe to defer PCI in lesions with FFR more than 0.8. FFR guided PCI has superior hard outcomes compared to angiogram guided PCI in multivessel disease, as was shown in the FAME2 trial. FFR may play a crucial role in decision making in multivessel CAD, favoring FFR guided PCI as compared to angiography guided CABG, particularly in patients with low syntax risk scores. The emergence of non-hyperemic pressure ratios may be a potential game changer in the future with more emerging evidence. Particularly, IFR is now guidelines recommended on the basis of RCT evidence. The integration of functional testing can significantly reclassify angiography-based risk scores like the syntax scores, which will further help improve decision making in the context of multivessel stable coronary artery disease. Thank you for your kind attention.